staying with us to talk directly with our group leaders. We've got several leaders here from Chicago area, Wisconsin, Tennessee, and Michigan with us today. So we're going to just have a very informal discussion with Heather about how, as leaders, we can talk to the folks who attend our meetings about incontinence and other really personal issues. So, and this is, like I said, it's not formal. It's just meant for all of us to kind of have an open discussion, and everybody feel free to talk, and we'll pass the mic around just so we can make sure everyone is heard for the webcast and the videotape. So thanks, everybody, and let's just get started.
Thank you so much for all what you guys do, and I appreciate you. Having support group leaders is essential to the recovery process of prostate cancer, and it lightens the loads for all the patients. So today, I just want to, ask you, do you guys ask your participants about incontinence?
Not really.
Not really, okay.
If the subject comes up, we discuss it to whatever degree we can do it without being medically professional. It comes up on a rare occasion if our program is aimed towards incontinence. But as a normal procedure, I personally don't bring it up unless it becomes part of the discussion.
Thank you, and that's what I figure because it is such a personal topic. Is it something you address in your sessions?
I do a survey with my group at least once a year, asking them what subjects they would like to talk about, if they have a specific person they would like to come in. So I try to provide them with a doctor or a physical therapist or whatever who would cover that area. So actually in this last February, I had a pelvic floor PT come in and speak to us,
Right.
and she was awesome. And several of us ended up going to see her, which included myself. And so I try to let a lot of the people I have come in and speak are people I've seen or want to see or whatever. And so she was great. And, I do the pelvic floor exercises. Question for you, though. So doing Kegels, do you recommend doing them lying down, sitting, standing, and walking?
That's an excellent question, and it really depends at what part in your rehab you are, and if you know what you're doing, and if you're doing it correctly. So the best way to start learning to do your pelvic floor contraction is usually when you're laying down. And then from laying down, I'll recommend that patient goes from laying down to laying on their side to laying on their stomach, just in different positions so that your brain gets the muscle memory of working those muscles in different. Then you can go into sitting, and then from sitting to standing. So obviously with standing, it's going to be the hardest way because you're standing up against gravity. So usually when you're starting out, I'd always recommend lying or lying and sitting, just to make sure, because otherwise, if your muscles are really weak and you're trying to do them standing, a lot of times then you might be doing more gluteal or butt muscle activation, or you might be holding your breath or trying to do other muscle compensations. So great question, thank you.
When you get real coordinated, you can try doing them while you're brushing your teeth in the morning to save time.
Without a doubt. Yes, and then from the Kegel exercises, when you get really good from that, we also teach pelvic floor muscle coordination exercises too that we can share as well. So, is there a question?
Do you use biofeedback
Yes,
in any of your
I
diagnosis?
do. Well,
yeah.
first of all, biofeedback is a big word that has many meanings. My best biofeedback is my finger, actually, and I will do a rectal exam on all men who come through my door, and that's how I can test to see if they are activating their muscles correctly. Now, for some reasons, people don't want to do that at first. I do have biofeedback both through with the computer or through the real-time ultrasound. So those are both things that I have available to me in my office. And depending on, there's a lot of pelvic floor physical therapists in the United States, and I'm always happy to help you find one, or you can always look on the website through the American Physical Therapy Association, find a therapist, and you can look to specialize in pelvic health, or you can go to, as I said, it was the section of Women's Health, and the name changes to the Academy of Pelvic Health. You can look there for somebody. You can type in your zip code or look in your state to get different resources for people. But every pelvic floor physical therapist, you know, usually has a basic training in the biofeedback. They may not always have the equipment. Now, the real-time ultrasound, I mean, I do have that at UIC right now, but that's also a $40,000 piece of equipment. At the previous hospital I worked at, I worked for a couple of years to get one, and we finally got a small little model, and that was still $15,000. So it really depends, but that is a common thing that pelvic floor therapists usually have some aspect, whether it's the real-time ultrasound or the biofeedback through the computer.
Yeah, because several of our members tried doing Kegels, and then when they got referred to a physical therapist, they found out they weren't doing it right, and they found the real benefit of having the biofeedback and then working with the therapist to learn how to do it properly.
Yeah, and that's huge, and that's where some people will say to me, well, I've been doing them all the time, but I'm getting no benefit from it. And my first question is, well, how do we know you're doing it correctly? And 9 times out of 10, when somebody reports that to me, and if I see them in my office, they're usually doing them incorrectly. So it's really important to make sure they're doing them correctly.
So assuming that everybody does the exercises routinely and correctly, is there a particular point when you might say, well, this just isn't working, it's time to go on to an external sling operation or something like that for urinary incontinence?
Yes, I was going to say with that, it's very person dependent. You know, I think that I'll never tell them to stop doing the exercises, because even if you need additional procedures on there, we still want you to have strong muscles. And any procedure that you have is not going to make your muscles strong. With, like, you know, when they go into a sling procedure, that's pulling it up. So we'll look at our work in physical therapy, we'll look at how much leakage there is, you know, and then we may refer back to the doctor to say, we're making progress, but there's still quite a bit of leakage, and then we refer back to the doctor. So I would say there's never a point in not doing exercises, and in fact, I feel strongly that if we all brush our teeth every day, we should probably all do our pelvic floor activation every day. And it sounds like it's difficult and hard, but it's really not once you know you're doing it correctly.
So except for the, one more question, except for the really extreme cases where they just need to have an operation, would you, the normal person that you see, patient, is there like a standard recovery time, or again, is that individualized?
It's very individualized because it depends on so many things. It depends on, you know, what was the surgical procedure they had. It depends on how involved was their prostate cancer, how involved was it getting the prostate out? Was it a nerve-sparing technique? Was it not a nerve-sparing technique? It also affects on what was, you know, your physical level and your health level before going on. Do you have comorbidities? If you have diabetes, diabetes is going to be something that is just going to slow the healing process. So for people who are diabetic, they will have a slower healing process. If you're a smoker, that will slow the healing process. You know, so there's a variety of things. You know, if you're strong and healthy and you don't have any comorbidities, you would expect to have better outcomes, but then it also will depend on the surgical approach and how easy or hard it was to get out the prostate. Was there nerve damage? A variety of things like that.
So it sounds like you're saying never give up.
Never give up, and exactly, and that's why it's really important, once again, you know, that we refer out to other medical professionals. You know, depression and anxiety, unfortunately, comes into cancer diagnoses quite a bit, as well as incontinence and pain issues. So those are always good to have good resources for psychology, for psychiatry, you know, just to treat the patient as a whole and not just their prostate, but mind, body, and spirit, and for what you guys do.
In other words, what you're saying is you have to tailor the therapy to each person individually based on that person. There's no gray area. It has to be a black and white situation for each patient.
But there's always gray, you know.
Well, yeah.
But yeah, so I mean, there isn't an exact cookie cutter, you know, prescription. I can tell everybody that we need pelvic floor strengthening, but you may be able to do yours in standing and hold for 10 seconds. You may be able to do yours in sitting and only hold for 3 seconds. You know, so there's a variety of factors. You know, when we look at, so that's why we can start by giving pelvic floor muscle activation exercises to everybody, but then if they're having problems, that's when you want to send them to a specialist, or, you know, your urologist or oncologist may send you, you know, before surgery to see a specialist to give you a little jump on the gun too.
Short of making a referral to you or someone like you, what can we as support group leaders do to help men, first of all, do Kegel exercises or pelvic floor exercises, and secondly, help them make sure that they're doing them correctly? Well, I think there's a lot of information we can get, and education is really powerful, and you guys really are the first step. You know, and that's where I'm hoping to work with us too, and we're going to get some instructional papers to you guys about just isolating pelvic floor, some general instructions. But once again, if they're not working for somebody, then send them to the doctor, then ask them to go see pelvic floor physical therapy, because we don't want them to spend 2 years doing the wrong thing, be completely, you know, but before we get to that point, we got to be able to open up the discussion. And I want to empower everybody here to feel that they can do that and they can talk about it. I often laugh to a certain degree because I wonder what my grandma would think of what I do for a living. Because I need to tell you that my grandma didn't have a pelvis. My grandma didn't have any sex. So which obviously, you know, I'm joking. But it was just something that you didn't really talk about. And we come from many different generations and many different backgrounds and cultures that may, you know, really keep these things private. But in this scenario, and when we're talking about prostate cancer, I encourage you all to, you know, you can do a yearly survey, you know, and ask people and have it be anonymous so that nobody feels like they're being put on the spot. And do a session where that you can ask for a local person to come in and give a lecture. And if you don't have those resources in your area, then there's a lot of ways that you can get information that you can say, let's talk about anatomy. Does everybody understand where the prostate is? And look, it affects these muscles. And I've read that research, you could have up to 90% of incontinence, you know, and so if we just say 90% of this group right here, and we got 2, 4, 6, 8, 10, that means only one of us would be continent. So, or the most of the numbers say it's about 60% to 90% in there will have incontinence. So that means, you know, only you guys potentially would be continent, and all of us.
Lucky guys.
Wow. Well, okay. Wait. Maybe no. You know. So, you know. So I mean, if you start by just talking about like what to expect with prostate cancer, and there's so many big questions here, but I think it's really important to dedicate some time to incontinence. You know, whether it's through the survey. You know, we can talk. I can gladly give some, you know, research, some short little abstracts about research about pelvic floor muscle strengthening, and you can say, you know, how many people in here do pelvic floor muscle strengthening? Now, some people may admit they do, some people may not know what they're doing, and then you can go through some basic information.
And how many people know what it is?
Exactly. Or how many people know what a pelvic floor therapist is? How many people have been to pelvic floor therapy? I think there's a lot of good questions, or you can go from that route. You can also go to saying, how many people sleep through the night? How many people get up to go to the bathroom? What is normal? So asking basic questions of like, what is normal? When somebody says, well, I go to the bathroom 5 times a night, it's like, wow, that's really going to affect your quality of life, and you're going to have sleep deprivation. And did you know there's actually something you can do with it? It's about retraining your bladder. So we can ask questions, we can plant questions, and even if your audience isn't responding, saying like, okay, how many times is normal? Well, did you know it's normal? If nobody's giving you any, if you're pulling teeth from your people, arm yourself with the information so that you can kind of lead a little bit of a discussion too. Did you have a question?
Sure. Working with Katie, my pelvic floor PT, also learned that you have to learn to relax your muscles.
Without a doubt.
You strengthen and learn that through the biofeedback, the probe, that, you get to this level, we need to work up this level, but you're also not relaxing them enough. You need to get back down to this, so.
Without a doubt. And once again, not everybody is going to have the biofeedback, and you still can learn how to effectively, strengthen or contract and shorten your pelvic floor muscles, as well as lengthen and relax your pelvic floor muscles. And sometimes people don't have that body awareness, and that's where you can start with biofeedback when you're working with a therapist when they do a digital exam. Or there's lots of other ways too to promote, just by even starting with deep breathing. So it's very important both for the contraction and the relaxation. And a lot of times too, when we have leakage episodes, we tend, or if we're prone to leaking, we're going to tend to try to tighten, and you can't walk around tightening all the time. As I said, that can lead to some muscle dysfunction.
One of the muscles you said that was short in men mostly is the hamstring.
That technically is my personal bias,
but I
but got
think
some
you're probably
experience
right.
with that.
So I guess my question is, at this stage in many of our lives, we're not young whippersnappers anymore. If you do that stretching, can you permanently lengthen it and permanently change that, or is it always going to be kind of tight?
Well, I think you can always improve. It's individual. If I went and measured all three of your hamstring lengths, I bet I'd find different levels, and where some may be very, very tight. When you do a stretching program correctly, and that's, when I mentioned earlier that when we do stretching, research shows we want to stretch for 30 to 60 seconds, make sure we're breathing, have good form. Yes, you can slowly lengthen. So, and a very easy one, as I said, is a chair stretch, putting your foot up and just leaning forward. So, but yes.
I think, so I've done that periodically, but then I haven't for a while, and it gets tight again. So I guess you got to keep it up.
Yeah, you got to keep it up, just like brushing your teeth every day.
Row.
I go back to that.
Kegels.
Yeah. So, but no, it's really important, and sometimes, depending on where you are, what your resources are, whether you can work with a physical therapist, an athletic trainer, there's different levels of where you're at. Sometimes people can put you on a small little exercise routine so that you have a daily, home exercise program that you can do every day. And that's really important for anybody, regardless of their age. So.
I just think of something to say. As a woman support group facilitator, sometimes the men don't feel comfortable talking about things like this in the presence of a female. How do you get them to come to you and not feel uneasy?
Oh, I have my mic on. Well, I would always say usually my first session with any patient is always really the hardest session, because I'm trying to get them to trust me and to realize that I actually do care and that I can change. So sometimes it's about reading your patient or your support group members, and sometimes just putting information up there, giving resources in your line, and just saying, hey, research does show that people have incontinence. Is anybody struggling with this? And once again, if nobody's answering, then you can talk about basics. Here are some handouts I want you guys to take home and read over, and we can talk about this next time. Does anybody have experience with a pelvic floor therapist? But also, from my perspective, sometimes I'll say, do you want to know about me? I went and got I have my bachelor's, my master's, and my doctorate. I tell them about my experience, and I actually really love what I do. I mean, I deal with pee and poop for a living, and stopping pee and poop for a living, and pain. And I understand the impact it can have on people. I understand it personally from family members and professionally. And so it does really matter to me. And I educate. And so and any person who walks through my door, as I'm doing the evaluation, you know, I'll pull up the anatomy and I show them the anatomy and I'm like, and this is your prostate and these are these muscles and these are what these muscles do. I've had people who've come to me for incontinence who tell me they have no leakage. And usually by the second or third visit, then they tell me they have leakage. And I said, well, I figured that. You know, but it's about educating, and so they understand what's going on, that understand that they're not the only person. It's very common, you know, for people with incontinence to feel like they're suffering in silence, to understand that nobody else has these problems, but that's when you get your facts. Over 25 million Americans suffer from incontinence, and there's different forms. And if you have prostate cancer or have had a prostatectomy, you're going to be at a higher risk for having incontinence. And in fact, you're going to be at risk, depending on the research, from 60 to 90% or around 60%. Erectile dysfunction. Let's talk about erectile dysfunction. And as a woman, I've been told, like, well, you know, you don't understand. And I said, well, no, I don't have a penis. But I can tell you that this is what the research says. I've studied this. I know it personally. My father died from prostate cancer. I have other people. My uncle has prostate cancer. It affects everybody. So it's really hard to go anywhere and not meet somebody with prostate cancer. So, yeah.
And then, as somebody who's dealt with prostate cancer twice, I mean, we always see as females, whether it's a nurse, a physical therapist, a radiation therapist, a counselor, cancer counselor. I mean, that's 95% of who we deal with is females. So you just kind of get used to being embarrassed.
Well, I was going to say, and on the flip side, being a female and having childbirth, you know how many people come in through that? So you get used to it. So, but it's also, it's nothing to be embarrassed about. Like, these are just facts that unfortunately we all have to pay taxes. We all are going to die someday. Those are facts that are there. 2 + 2 = 4. And we want to present the facts to people and show that we have empathy and compassion as we do it. And sometimes it's like, well, no, I don't know what it's like to be a person with prostate cancer, but I do know what it's like to lose somebody that you love from prostate cancer. So I have it from a very different, and I see people come in my office every day, and I see the impact and the quality of life, that I've helped improve people's quality of life. I've helped improve people be able to return to having intercourse, and those are really personal things, but they're important things for quality of life too. And you know, I am a Caucasian female, and I've worked with a lot of different cultures, and I've worked with also interpreters with Spanish and Russian and Polish. And I had one man who was like, okay, so when is the doctor going to come in? And I'm like, I am your doctor. I'm a physical therapist. I have a doctorate of physical therapy, so technically I am called Dr. Moki, but I'm not a medical doctor. So just call me Heather. And he's like, but you're a female. And I said, yes, I am. You know, and I said, but I've also done my master's and my doctorate in physical therapy. I've traveled around the world, and I do lectures, and I've learned going around the world. I'm working on research. I'm doing this. And actually, I understand what you're going through. And he said, really? And so then I start talking about some of the basics of it, and I slowly gained his trust. And so that's what you have to do too in your support groups for new people who come in, or harder topics too. Other questions? Or
Well, as leaders too, we need to be advocates and try to get out and talk to others. And you know, I haven't tested, so you know, I'll go on the radio and do things. This past June, Terry was looking for somebody to possibly speak to a Oncology Nurse Navigator Summit in Chicago, and I volunteered for that. So I spoke to 300 people there, and I think there was one male in the audience and 305 females, which is typical. And evidently they liked what I said, because then they had me write an article now, which they just published online this week. So we need to be out there, because the medical groups now want to know more about what the patient's feeling, because they're starting to believe a lot more, and we need to know that to treat them better.
Yeah.
And so I'm seeing more and more of that. So.
Well, and that's not being scared to talk about your experience and talk about the symptoms that come along, even if some people feel they're very embarrassing. We want to kind of dismiss that and more give empowerment to saying, well, there's things you can do. You know, when we look at incontinence, there's medications, there's surgeries, there's physical therapy, there's behavioral training. Were you aware of all this? You know, and sometimes they get a little piece of it, but they don't have as much, and that's where we want to educate and give resources. So thank you for what you do. That's really powerful and really important, and especially with your experience, you know, it's more of an impact. So, other questions?
The problem is that when things start to happen as you age, and you do not have the control that you used to have when you were young or younger, it seems that you are now getting to the point where you are losing control, and that becomes more of a, not more, but part of it is becoming more of a mental problem in addition to the physical problem, I would think.
I think a lot of times, and I work with pain and I work with incontinence, and I'll say we kind of you can get stuck in this vicious cycle. You know, I mentioned earlier with incontinence, we can get socially isolated. We don't want to go out. We're scared to go out. Then we get sad and lonely and depressed, and we get stuck in this cycle. We see it in pain cycles. You can see incontinence can lead to some of those cycles. Aging can lead to this. And I mean, I have patients tell me, it's like, all I do, my job is going to doctors. That's what I do. I go from one doctor to the next doctor to the next doctor. And, you know, that's maybe where they are right now, but that's where it's a good opportunity, I think, to introduce counseling or talk with your doctor, you know, about it, because there are changes of life. I mean, the good news is with all our medical advances, we're living longer, but that also means sometimes people are going to live longer with problems. And also, too, I think it's really important that if you aren't happy with your doctor, if you aren't happy with your medical professional, you're the one who goes to them. You're the one who is paying them. It's important that you feel somebody that you can talk to, that somebody may talk to you about hard topics, too. And even, you know, question about depression or anxiety. We see more and more people in our society dealing with this, and we need to acknowledge it and address it. And as support group leaders, that's a question where it's obviously none of us are psychologists. Well, maybe some of us are psychologists here, but not everybody is. But that's where we can talk about exercise and getting up and moving. That can get rid of some, you know, depression. That can get rid of some anxiety. That can give you more control. So it's questions of how do you, you know, facilitate people getting more control back into their life too.
Anybody else? All right, guys. Well, I'm gonna like cut right across here, come over here, and
Want the microphone?
Yeah.
So that's really it. But I just wanted to kind of go around the room and thank everybody here. We've got Norm and Donna and Flora and Len and Heather, Cliff, Jim, and Harvey. Thank you guys so much. Thank you everybody out there for watching. And we will have, we're going to be working with Heather a lot and providing these materials for you guys to use at your groups. And we'll also be posting some things on the website. So.
And if you do have questions specifically for me, you can contact Terry and she can send it on to me, and I'm happy to help answer your questions to my best of my abilities.
Okay. All right, guys.
Thank
Thanks,
you.
everybody.
Good luck.
Signing
Thank
off.
you.